there's some areas in the body that are, we'll say, encased in bone. We'll say surrounded by bone, and that typically includes the skull and the rib cage and the pelvis. And you can see, if you know anything about these bones, they are particularly thick and particularly strong. And they have to be, because they are protecting something. They are protecting the organs they encase. And that can include the brain, the heart, and then many of the pelvic organs, including the bladder, the uterus, and the rectum. And it's a very, very important thing that they are thick and capable of resisting impact that's typically from the outside coming in to any of these points. But they do something else by being in this structure, by being relatively thick and strong. They become less mobile than other areas of the body. They become less capable of moving. And this is actually a good thing for other reasons, because it resists harsh motions in any direction that might put excessive strain on the tissues of these organs that are relatively delicate, that could potentially be damaged if they moved like other areas of the body. Now, just as a comparison, we'll start with a relatively unprotected area. We'll talk about the gut, or the stomach region. In this rough region right about here, there can be a fair amount of impact injuries. Consider how many punches a boxer will take on the average day, or even throughout their career, just an immense amount of force. And certainly there is a protective layer here. There is the peritoneum, and specifically the greater omentum, that fold of the peritoneum that covers up many of these gut organs. But that being said, it's not that big a layer. It's not that deafening to a blow, certainly not more than we see in these other regions of the body. So the stomach, unprotected, seems to be okay with that. However, we don't have the same thing going on in the other areas of the body. So let's say this funny looking, J shape here. This is the thorax, just sideways. It's a lateral view. Now, the thorax will have, specifically the ribcage, will have a respiratory diaphragm working through the bottom, going this vague direction, superior to inferior, and slightly oblique downward. And it goes up and down as we breathe, and this is just a normal thing. Hopefully you're breathing well. But with it comes along the organs attached, and that can be the lungs, which is important. The lungs are quite adhered to this respiratory diaphragm, through a tissue, of course, but adhered to it. And so when the respiratory diaphragm drops down, it pulls down on the lungs. It decreases the pressure, and the air rushes in. It's all really important, all basic stuff. I'm going to just remove this lung layer for clarity's sake. Know that it is there. The heart is there too. And the heart, because of some of its attachments, does move up and down with those lungs, but not in exactly the same way. There is a difference. We want to protect this organ that could potentially be injured if it was moved too harshly, and this shows up in the anatomy. Kind of like a peritoneum that we see in the gut, there is a pericardial layer that wraps around the heart, but leaves a little bit of a gap in the front. It wraps around the back and the sides too. I'm just going to draw it from more of a lateral view again. I've drawn it too big, of course. This isn't actually accurate of it, but just for illustration purposes, this makes a little bit more sense. In any case, there is attachment to the diaphragm through what we call the pericardial phrenic ligament. Anything with phrenic, it's the respiratory diaphragm. And so it does attach, but it leaves more of the front part of that heart to hinge a little bit, if you will. It leaves it to swing free. So even though there is some inferior word pull, so there is some pull and maybe a little bit of stretch on that heart, it also swings backwards and forwards with breathing, with respiration. So we know the heart is being prevented from moving too far into a stretch position. And this is, again, by design. We all have this little bit of a gap in our attachment through there. Now, an even better example, and this is getting more and more well known, thankfully, is our brain's encasement in the skull. It has the consistency of jello or wet tissue paper. It is a very flimsy, flimsy structure. And it's well designed, don't get me wrong on that. But any kind of significant impact that would shift the bones, imagine if you could shift the bones like you shift your elbow, it would cause catastrophic damage to that brain, to that soft tissue in there, to that very soft tissue. This is one of the better examples of this exact thing. Why we need these low mobility bones here. Why this is in fact by design and essential. It's a good thing that we have areas that don't move nearly as well as other areas. So, that being said, these essential low mobility areas require higher mobile areas to make up for that low mobility. You can't take it all away without giving some back. Now, thankfully, it's a bit predictable. It's in a few spots where we see the highest amount of mobility. I'll just go through them now. And it's usually at what we call transition zones. So one being the occiput, atlas, and axis. That's the lowest bone of the skull, the first cervical vertebrae, and the second cervical vertebrae. So that's 0, 1, and 2. And many of us know that we get a great deal of rotation through the AA joint, the atlantoaxial joint, C1, C2. 50% of the rotation in the cervical spine is from there, so an immense amount. And some would consider the AO joint or the OA joint, the occipital atlantal joint, to be pretty mobile. I would, because I think it has some interesting side shifting capacity as well as a good deal of flexion extension. We don't see that lateral translation, the side shifting, in too many other places. So this is an area of high mobility. It goes from skull, low mobile, to cervical spine, high mobile. This one can vary a little bit. The next one, C5, C6, tends to have a little bit more mobility. It can shift up or down. If I'm off by a segment, by your opinion, I'm okay with that. I'm wrong lots of the time, and it's no big deal. But we have a fair amount of side bending and rotation here. The neck really is an area of high mobility in general, sandwiched between these two areas of very low mobility, the thorax, the rib cage, and the skull. But nonetheless, C5, 6 is about a place where we get some real good mobility. Transitioning downward, we have this thoracic cage, which has one of the better names for anything with low mobility. It is quite, I'll say, locked up in the front. It is a cage. And if I just take away, let me just clear up some of this imagery here, you'll notice that on the anterior side, the front side of the thoracic cage, everything right down to T10, this lowest rib here, attaches to the sternum. That's all the way from rib 1 all the way down to the 10th, is fixed in the front, but it changes as we get to 11 and 12. So the 11th and 12th rib, let me just clear some of this up here, get rid of that. The 11th and 12th rib, by comparison, are relatively free. They are embedded into some of the abdominal oblique tissues, a little bit of the QL, of course, but they're not as structurally fixed. They're not as fixed by bone. And this allows for a great deal of movement here, usually rotation, but certainly we get some side bending in this area. So again, transitioning from thoracic cage all the way to the lumbar spine. We could make a case for L3 being good in extension. I'm just going to omit it in this case because it's not nearly as much as the others. Then we get to L5. It happens to be just above the pelvis, the sacroiliac joints, which, though they do move, it's not that much. It's important, but it's not that much. And at L5, S1, L, the fifth lumbar, on S1, we again get a fair amount of side bending and some rotation as well, coming from between two relatively less mobile areas. And what this means ultimately is because these small regions are doing quite a bit of movement, is that they are involved in some very big motions. Smaller movement, yes, overall smaller parts being contributors to that movement. They help to create those bigger movements in a larger way. So let me throw in just an ambiguous swooping line there. Most of my posts are based on ambiguous swooping lines. But the fact is, many of these points are made to contribute to, whether that's L5S1, to bigger motions than some of their larger counterparts. Small things doing big motions. That seems to be the way of the human body. And that means on a practical level, really what this comes down to is that if we get changes in these seemingly small areas, whether they increase motion or reduce it, whatever it happens to be, you're going to see it show up quite readily in your functional assessment, your understanding of how a person's moving and how healthy their movement patterns are. When these small areas, seemingly unimportant at times, when these small areas start to move better, you'll notice the whole body starts to move better. When they start to move worse, on the other hand, the whole body starts to move worse. So it's worth looking at these spots. We're looking at these spots when we've got big global things, even though they seem tiny, even though they can seem insignificant at times. They're well worth looking at. And of course, every part of the body is equally important. Everything deserves recognition and detailed analysis. But some parts are more about mobility, and some parts are just more about security. And that's good. It all works out in the end.